don't want to come in. They only come in rarely. They don't want to come follow up. So you got to reach them too, and you got to convince them to come in, develop those relationships, outreach to them, have some kind of, we have a whole outreach arm within Kaiser of, you know, mailing and calling and asking these people to come in and try to reduce co-payment barriers for them, you know, come in for a free nurse blood pressure check, you know, so you don't have to necessarily schedule and have a co-payment with your doctor. If the cost is a barrier, the doctor can just titrate you by phone if you come in and get the nurse to check your blood pressure. So trying to reduce barriers and do in-reach and outreach, kind of a combination of things, and then having the electronic health record programmed with whatever guidelines your system is using and the protocol that we chose. Somebody mentioned Crinzide as our first choice for blood pressure, and we also use the ACCHA blood pressure, cholesterol guidelines. And I'm working with AHRQ group there's a repository they're building for electronic decision support. So any federally qualified health clinic, for example, in LA, can go to this repository and grab this computer code that has the ACCHA cholesterol guidelines all ready to run on individual patients and say, oh, this person's ASCVD risk is 16%. Start statin, start aspirin. You know, real simple messages like that. And you can even tee up the orders so the doctor just has to sign it. That's how we try to tee it up for doctors, that it's easier for them to just sign it and send the patients on the meds than to just treat the back pain and to undo all that, because we tee it all up in the health system. It's almost the path of least resistance is treating patients the right way.
I think that's key.
Yeah.
We figured out with our CHIMP protocol a long time ago. Everybody wants to do the right thing, and if you make it the easy and the default thing, they'll do it.
Yeah.
How about Kelly Green and then Carol Zaher?
I'll just add a couple more things onto what Ron said. Kelly Green, also from Kaiser. Champions are huge advocates, physician champions, pharmacy champions, and a lot of our infrastructure is built on these, you know, powerful, enthusiastic champions that push our leadership to do the right thing and push their peers to do the right thing. Unblinded performance measures are huge in Kaiser. When I came here 15 years ago, a few of our medical center areas, I think Orange County was one of the first to start doing unblinded share. They send it out in an email, the charts right there, pasted in with their performance for blood pressure control. We've been doing more and more telephone visits. I mean, it's mushrooming because it's so convenient for patients. And academic detailing, and that's not high tech. I mean, if you have systems that have experts that can go around, when you identify your providers who are not good performers and somebody stops by, our pharmacists do a great job on academic detailing. And really, when it comes right down to it, when you look at your really good performers for blood pressure control, you know, their patients love them, they don't have a high no-show rates. So often it comes down to how you do it. And when Mike Cantor says to me, our head of quality for all of Kaiser, you know, well, why does this provider do so well and that provider doesn't? I say, you know, you can't change the way this provider talks. I mean, you can do a lot of coaching, but even care managers on the phone, you've got some that are really good, and those patients just want to do what and they're very good, and you've got some other care managers. It's so much of it, when it comes down to that 2% difference, 3%, 4%, it's how you do it. That's one you kind of can't train. Train a little bit, but not really.
Yeah, sharing the best practices, though, with the unblinded data, you can bring a lot of the lower performers up. And so over time, some of the low performers sometimes become high performers. Okay? They put a lot of energy into it.
So we had a question from Carol Zaher from HealthNet.
Yeah, let me just comment. In a former life, I was at Kaiser, and the things you mentioned are absolutely, well visited there. And I was part of the initial process many years ago when the unblinded data started coming out, and that was quite traumatic for those of us who practice, because doctors tend to think we're all doing 95%, and when we get the statistics, sometimes it doesn't reveal that. So that, I agree, somehow bringing the data out and showing where you stand amongst your peers is nice. And also what you said about 80% the in-reach, which we're calling that, I think that's where a lot of the rubber meets the road in getting practice changed. And as you said, you know, making it simple. You can make the simpler you can make it for the doctor, who has obviously a lot of things to do and you know, a lot of being pulled in many different directions. But if you can make it really simple to do some simple things, I think that's the great first start. With respect to the outreach and the patient, I'm just, you know, talking about billboards and whatnot. I just, and Dr. Watson, you sort of mentioned this, how can we get what the dermatologists do for melanoma and skin cancer? Just yesterday, I think I was watching television, which I don't do too often, but I was sort of mindless. And it struck me that there was a commercial for 1-800-QUIT for smoking. And it was a woman who, you know, had a trach and sounded awful and looked bad. And, you know, that's very dramatic. Now, it still doesn't get everybody to stop smoking, but it does get some attention. About an hour later, I was watching some other show that talked about a family member who had died of a heart attack. And the son hadn't gotten there in time. The father passed. And the son's comment, which I thought was interesting, was, you know, he felt guilty about not getting there in time. And he said, well, you know, everybody has a heart attack, and, you know, most people survive. I thought, you know, we had time to get there, that this isn't, you know, as big a deal as maybe in the old days. And when I heard that, I thought, oh, yeah.
You're exactly right. We are a victim of our success. No one's afraid of it anymore because we all do such a great job of keeping patients alive. We're still really afraid of stroke.
Yeah, that's right.
We're really afraid of cancer.
And
Doing as good a job as us.
I was just going to, because my clinical background is as an intensive care physician, and I'm somehow thinking about those discussions you have with families, you know, those last days when everybody knows the patient's dying on the ventilator and everybody's just hanging out for that miracle that might happen, and thinking about, to your point, how do you rewind that realization of really time's up here to, oh, if only, you know, he'd lost weight and we've done all those things, because somehow in cancer there's that connection. But for heart disease, and we seem to somehow, I think, have lost a little bit of that connection about where we could end up. So I think it's, going to your thing about the adverts, I'm struck here that maybe I don't watch enough TV here in the US, but I'm struck by the UK will do brutal public health television advertising, like really brutal. I don't know if has anybody seen the one, if you've ever been in the UK, there's one about putting a seatbelt on in the back seat, and the mother is taking the child to school. She jams on the brakes, and the child shoots forward and decapitates the mother on the school run. Now, that didn't take long to get everybody putting their seatbelts on, so you know it does actually work. I mean, you want to take it down a little bit, but you know they've done that with public health. Really, you know, this is an emergency. What are we going to do about it? So, kind of making that reconnecting that fear almost, but to engage people to do something about their own health. And just going back on a more positive note, the Pfizer thing. I mean, some of you came to my talk about, you know, improvement happening around the world. Those things that you're saying, using the competition, making it really simple to do the right thing, are generic. They're not just Kaiser. They're for everybody. It just works in any way you do it. So, and I think that was one of the problems with those different blood pressure numbers. It confuses people, so it gives them options about, you know, where to go, rather than just being very, very clear. This is your number. This is you get treated.
I just wanted to make one comment in terms of your type of, you know, campaigning. I think we all recall when Nancy Reagan was leading the "This is your brain on crack" or whatever, she had a pan, and yeah, you know, I think certain, I guess, class of people.
It has to be done very carefully.
Yeah, maybe, you know, attentive to that type of advertisement and campaign, but when you talk about a certain SES. They're not looking at that as a fear. I think they have other issues that they're trying to deal with in terms of priority. So it doesn't really, that type of campaigning doesn't necessarily help the population that we're actually trying to help.
I think something that starts the conversation again within the society, though. You know.
Dr. Chen?
Yeah, just a comment. I think the data show that patients with better health literacy tend to do better in terms of health outcomes. I think it's speaking to that as a physician, a lot of the work I try to do with my patients was educating them. And my grandmother taught me a lot. She used to take her blood pressure 2 or 3 times a day in a quiet setting and keep it long. And I try to convey that to my patients as well. So I think part of the answer is self-empowerment, education, self-empowerment, and then public health. Because if we can teach them how to manage their own blood pressure, this is why I think non-pharmacological intervention is so key. You're hypertensive in the afternoon because you just watched Jerry Springer, and you go to the doctor, things like that. A common sense kind of approach. Looking for parking spots, right? Listening to the news, things like that. I mean, if we use kind of some common sense, self-empowerment approaches, I think we can maybe bring the curve down as well.
Tony? Dr. Quo from LA Public Health?
Yeah, I was going to mention, it just occurred to me, that talking about advertisement, I know CHC in South LA a few years back actually had a campaign and program where it's basically, it's called Know Your Digits, and I think their approach was trying to get people kind of empowered and understand knowing their own numbers so they can do things with it. The one unique things about, I think, what they were trying to do was they also try to address some of the practical issues, the diet, even how to sign up for food stamps, because a lot of things, you are right, this is where we're getting into that social determinants of health, like the exact population that we are not being able to control blood pressure, actually their immediate problem is discretionary funding, it's housing, it's food insecurity, and probably not buying medication to control their blood pressure. That's probably at the end of their list.
I wonder how many of them know that if they follow a strict vegetarian diet, it's less expensive and healthier. And we're not teaching that. So, or even, if they're trying to save money and be healthier, even by just moderating the amount of meat that they have and shifting that more toward healthy fruits and vegetables, it's going to benefit them more. I don't think people know that at all.
It's hard though. It's like if you're working 2-3 jobs, you gotta pick up your kids, you can run through Taco Bell and for $1.99 get a warm burrito, chips, and a soda. The kids are full.
Yeah.
Who has time to go to the store? Plus it's more expensive. Get fresh vegetables, make some beans. You're beat down.
Yeah, so it's about how do we tackle that? Because you're exactly right, that if we're trying to make the healthy choice the easy choice.
And if people will do the right thing, if it's cheap, it's easy.
So how can we tackle that?
So our government subsidizes corn, and so we have a lot of corn, and corn syrup and things. They don't subsidize fresh fruits and vegetables. It's kind of crazy.
Taco Bell doesn't sell fruit salads and healthy yogurt and chicken that's broiled. So. Yeah.
And there's a high density of fast food, places.
In the poorest neighborhoods.
I mean, it's just a fact. I mean, just like those liquor stores.
It's sad, but it is much cheaper for a family on the edge to get that $1 menu at McDonald's and to dinner that way than trying to get something healthy.
Tony, is there anything going on in LA about that, about trying to get the fast food purveyors to have something that tastes good, that's cheap, on their cheap menu, that's healthy?
Well, we don't have a centralized approach to doing that, but public health, certainly we've been working on what we call healthy food procurement strategies, which is I know within the county of LA, we've passed a 100% healthy vending machine policy, which basically took out most of the sodas and in the facilities. We've had a motion back several years ago where it required Department of Public Health to actually comment and make suggestions in the request for bid for food services contracts, and we've been able to use that to sort of put in healthy nutrition guidelines, making sure there's sodium and calorie limits, even fat limits. City of LA has a good food purchasing program that actually functions in a similar way, and they've been trying to scale it into other municipalities. One of the thing to keep in mind about LA, as you know, is we actually have 88 cities in addition to the city of LA, and so anytime you want to work at that macro level, it's not as jurisdiction. It's not as simple as like, you know, people always talk about like, oh, New York City and San Francisco, but they have one mayor. We have 5 board supervisors and 88 mayors. But we are working. But we have models that actually helps us to try to scale this type of effort, right? Because our experience in tobacco control is the same sort of way. We've had to go through one city at a time to try to address some of this. But you could address it.
So at Gunderson, we did do some things along this line, working with fast food stores and convenience stores, McDonald's, and a few others, and at least providing, I don't know if you can call them healthy options necessarily, but at least low-calorie options and promote them. And we got pretty good penetration of that. And then in terms of just, we did that in the hospital cafeteria as well, but then we also made it a point to distribute unused food at the end of the day that was still healthy and passed all the appropriate regulations to local food distribution centers. So actually, we wasted less because like 30% of the food in this country gets wasted too. So there's some recycling, and there is some, convenience stores or fast foods, or there's what you get in these neighborhoods, right? You don't get Whole Foods.
So I just want to note that Kaiser has more than 80% of their enrollees at goal for blood pressure, and they live in the very same communities as everybody else is. So it's not because of the fast food environment. It's certainly a variable, and I think Kaiser's done a good job with having handouts for their patients saying, I was kind of shocked, frankly, looking at one of the beautiful handouts, this was years ago, that showed the sodium content of the different choices. It's like, you're kidding, that's like poisonous levels of sodium content.
And I believe Kaiser, you guys have healthy vending machine policies and vending policies already all in place. So they're definitely a leader in that arena.
So I know that we're trying to focus on the clinical aspect of all the participants in this room, but everybody in this room also works for a sizable employer. And like Dr. Peden was talking about the fact that USC has 30,000 employees. And so, coming at it from the standpoint also of the health systems that you represent, to try to deploy some healthy approaches internally, and also to reach out to the medical groups that you contract with about their very data. When I've met with medical groups, starting in San Diego, and showed them their blood pressure, lipid, and blood sugar scores, most of them said, we didn't know this data existed. And there are a lot of medical groups in Los Angeles, just like the 88 cities. Look at the number of groups here. So having a strategy to go out and build their awareness that we are trying to get them to goal, particularly on blood pressure, I think is just an easy starting place. So I'll just announce that next month, on May 19th, we are going to have a close colleague of Dr. Carol Watson's presenting, Dr. Richard Allen Williams. And Carol, can you say anything about him?
So yes, Richard Allen Williams is the founding board member of the Association of Black Cardiologists. He's been transformative in getting more people of color into the field of cardiology, and been a tireless advocate for all the things we talk about: blood pressure control, lipid control, etc. He is now the current president of the National Medical Association, which is the largest organization for African American physicians. He's big.
And he's a professor with you at UCLA, right?
He's actually a clinical assistant professor, so I haven't actually worked with him clinically. I've worked with him on a lot of these initiatives like this.
Wonderful. Well, today was a fantastic, thought-provoking discussion, and I appreciate so much that you took time out of your practice to come teach us all about this exciting progress that's happening on the clinical front. Really exciting. Now that, like as Carol was saying earlier, let's not let it take 17 years to get it out to the primary care practitioners to use it. So nice to meet the newcomers here today, and I invite you back on May 19th. We'll be meeting somewhere at the endowment. They move our room around, and I apologize for straighten it out.
So tomorrow's